Hello, welcome to the last lecture of the lecture series of neoplasia. Malignant neoplasm is a dangerous neoplasm. Why? Because it causes local and distant spread. It metastasizes locally as well as it goes to the distant sites. And the diagnosis of the cancer is very important for the therapeutic aspect. So today in this lecture we will see the different modes of metastasis, the process of metastasis and how we can diagnose the cancer. Neoplasm has 5 P's. Its neoplasm is persistent, purposeless, parasitic, progressive and proliferating. This is the characteristic of neoplasia. As I've told you that there is a history of tumor growth. There are 4 phases of malignant tumor. One is a malignant change. The normal target cell will be transformed into the malignant cell. The transformed cell will grow. The growing cells will locally invade and then it goes to the distant metastasis. So this is a 4 phase of malignant tumor. Did you know this? At least once a day, our immune system destroys a cell that would have become cancer if it lived. So our immune mechanism is very important, immunosurveillance against the cancer development. So we see what are the routes of spread of the tumor. One is by the direct spread, one is through lymphatics, through hematogenous or a vascular spread, transcelomic spread that is through the body cavity, and perineural spread that is through nerves. Now direct invasion. The growth of the cancer is accompanied by progressive infiltration, invasion, and destruction by surrounding tissue. In general, they are poorly demarcated by the surrounding normal tissue and the well-defined cleavage is lacking. So the well-defined uh, nodule is not there, the well-defined growth is not there in the cancer, in the malignancy, but the benign shows the well-defined, well-demarcated growth. So now what occurs? What is the mechanism of spread? See, there is a primary tumor. That primary tumor, the tumor cell will destroy the basal lamina. That destruction leads to escape of the tumor cell. That is known as invasion. They invade into the surrounding tissue and they invade the nearby blood vessel. And the intravasation occur of that tumor cell and the tumor cell goes into the circulation. This tumor cell will cause the tumor emboli and at one place where the proper microenvironment is there and the preferred microenvironment when these cells will get, they will extravasate and they cause micrometastasis and then they colonize, they get the proper blood blood nourishment through the angiogenesis and they grow and cause the distant metastasis. So how this is the overall mechanism of spread. Now what is we see the stepwise metastatic mechanism. See here, when you see the first step is loosening of the intercellular junctions of the tumor cells. See, tumor cells are combined with each other by the intercellular junction. So the loosening of the intercellular junction is the first step of the metastasis. The tumor cell has fibronectin and laminin fibronectin molecules. They have laminin receptor, fibronectin receptor. So they will identify the type 4 collagen at the basement membrane. They will attach with the basement membrane and then that attachment, due to that attachment, the type 4 collagenase, that is a proteinase enzyme, is secreted by the tumor cell, and that will degrade the basement membrane. Once the basement membrane is broken, then this cause migration of the tumor cell out of the basal lamina, and that is known as migration. It goes out. See, this is a primary tumor. It is going into the blood, and here it is coming out from the blood vessel and causing distant metastasis. This is how the metastasis occur. This is the spread of the tumor. This is how the spread of the tumor occurs. So when we see this is a primary tumor, that primary tumor will break the basal lamina, it will break the basement membrane by type 4 collagenase enzyme, and then they will intravase it into the blood vessel, which is already giving nourishment to that particular tumor. So here it goes into the blood vessel, and then it forms a tumor emboli by combining with the platelet and blood cells, and this tumor emboli will now extravase it wherever the tumor microenvironment is proper to grow to that particular tumor cell, that will grow here. And this is also, this angiogenesis will, here the foreign angiogenesis will occur, and that angiogenesis will nourish that particular tumor cells at the distant site. So here it is a primary tumor, and here it is a metastatic tumor. This is how the metastatic event occur in our body. This is how the cancer spreads from the primary site to other sites. Metastasis commonly occurs through the lymphatic spread, hematogenous spread, and transcelomic spread. Lymphatic spread is commonly seen in the carcinoma, but the sarcoma can also use this route too. But carcinoma generally spreads by the lymphatics. The pattern of lymph node involvement follows the natural route of the drainage most of the time. Like the carcinoma breast, upper outer quadrant spread into the axillary nodes. The inner quadrant drains through the nodes along the internal mammary artery. Later, supraclavicular and infraclavicular nodes will be involved. So, through the routes of natural drainage, the lymph nodes are involved. This is a lymphatic having a tumor emboli. What is skip metastasis? The local lymph node may be bypassed, and it goes into they will skip the local drainage area, the local draining lymph node, and the tumor cell will grow in other site. This is commonly occurs due to the inflammation, due to venous lymphatic anastomosis, due to some radiation. The channels have been obliterated, that can lead to the skip metastasis. Regional lymph nodes act as a barrier to the further spread of the tumor, at least for a few days or for a time being. The cells, after arrest within the node, may be destroyed. Drainage of the tumor cell debris or the tumor cell antigen both can cause reactive changes. So sometimes the node is enlarged, but you won't see the presence of the cancer cell into that node. You only see the reactive hyperplasia. But if the cell escapes from the destruction by our lymphatic system, then there is a spread of the cancer cell. So the enlargement of the local lymph node is commonly seen due to two things. One is through the growth of the cancer cells, and second is due to the reactive hyperplasia. What is retrograde metastasis? Due to the obstruction of the lymphatics by the tumor cells, the lymph flow is disturbed, and the tumor cells spread against the flow of the lymph node, causing retrograde metastasis. Now, examples of retrograde metastasis is carcinoma prostate going into the supraclavicular node, that is against the lymphatic drainage. The metastatic deposit of the bronchogenic carcinoma to the axillary node, that is the retrograde metastasis. Now, hematogenous spread. Typically, the sarcomas, the cancer of mesenchymal cells, spread through this route. Arteries, due to thicker wall, are less rapidly penetrated. Venous invasion is common. So the venous invasion follow the venous flow draining the site of the neoplasm. Example, liver and lung. All portal drainage of liver and all caval blood flows to the lung. So the liver and lung is a very common site involved through the hematogenous spread. Transcelomic spread. It is a peritoneal cavity. Transcelomic means the cavity, through the cavity, the cancer spreads. So peritoneal cavity, pleural cavity, pericardial cavity, subarachnoid cavity, and joint spaces. These are the different sites of transcelomic spread. Carcinoma of the stomach, feeding to both the ovaries, which is known as Krukenberg tumor. That is example of transcelomic spread. Through the peritoneal cavity, the stomach cancer goes into the ovary. Carcinoma of the ovary, spreading to the peritoneal cavity without infiltrating any other underlying structure. That is a peritoneal cavity spread. Pseudomyxoma peritoni. That is a gelatinous coating of the peritoneum through the mucin secreting carcinoma of the ovary or the mucin secreting carcinoma of the intestine, or commonly appendix. This is how the pseudomyxoma peritoni is look. This is a peritoneal spread of the adenocarcinoma, mucin secreting adenocarcinoma of the intestine. You see the very small nodules there, small mucin pockets are there. The whole mesentery is involved. Carcinoma bronchus and the breast carcinoma going into the pleura and pericardium. That is also a transcelomic spread. Spread along the epithelial lined surface. This is one other type of spread, which is also the cavity spread only. That is also known as a transcelomic spread. That means through the fallopian tube, the carcinoma is going into the endometrium to the ovaries, or from the endometrium it is going through the fallopian tube to the ovaries. Ovarian carcinoma going through the fallopian tube to the endometrium. Cervical carcinoma going into the endometrium to the fallopian tube. This is through the epithelial lined surface, through the bronchus to alveoli, through the ureters to kidney, to the lower urinary tract. This is the spread along with the epithelial lined surface. Spread via cerebrospinal fluid is also one type of mode of spread and implantation. Now, bone implantation is very common. The malignancy metastasized to bone. But certain malignancy has a preferential site for the bone. Like the spine is the most common site of bone metastasis. But all cancer doesn't go into the spine, or all cancer doesn't go into the bone. The breast carcinoma, lung carcinoma, thyroid carcinoma, and kidney carcinoma. This, or prostate, this goes to the spine very commonly. You can remember like bacon, lettuce, tomato, and kosher pickle. Bacon stands for breast carcinoma, lettuce for the lung carcinoma, tomato for the thyroid carcinoma, and kosher pickle, that is for the kidney and prostate carcinoma. If you remember all four food items, these are going, so you can easily remember that which are the most common malignancies which goes to the bone, which causes bone metastasis, and common site of the bone metastasis is spine. So the preferential metastatic sites are like breast adenocarcinoma commonly goes into the bone, brain, adrenal. Prostate adenocarcinoma commonly goes to the bone. Lung small cell carcinoma going into the bone, brain, and liver. Skin cutaneous melanoma very commonly goes into the brain, liver, and bowel. Thyroid carcinoma going into the bone. kidney clear cell carcinoma, bone, liver, and thyroid. Testicular carcinoma is commonly spread to the liver. Bladder carcinoma commonly goes to the brain. Neuroblastoma commonly goes to the liver and adrenal. So there is a preferential site for many malignancy to get metastasized. So common distant metastatic sites for each and every malignancy is different. Why this happens? The reason for organ selectivity is one is a mechanistic theory. It is determined by the pattern of the blood flow. Second is seed and soil theory, which is very commonly accepted theory. That means the provision of the fertile environment which is compatible for the tumor to grow. So tumor gets the proper seed and soil and very proper compatible microenvironment to get grow, and that leads to the preference of the organ selectivity. Secondary deposit in the lung. How does lung look? It's the multiple deposits in the lung. Breast and lung tumor commonly involve pleural surface and it causes pleural effusion. Ovarian and gastric tumor commonly affects the peritoneum and it causes ascites, that is peritoneal cavity fluid formation, fluid collection. There is commonly an inflammatory response in the lining with the accumulation of the protein-rich fluid and the inflammatory cell with the proliferation of the mesothelial cells and hemorrhage. This is known as effusion. So the peritoneal effusion and the pleural effusion is common with certain malignancies. See, this is a diagram telling each and every spread. Like if patient is having a lung carcinoma, the blood bone metastasis occur and it goes into the lung. This is a hematogenous spread. The local invasion of the lung tissue. Transcelomic spread that it goes into the pleura and the lymphatic spread that goes into the hilar lymph node. So spread of the lung carcinoma uses all four routes of the spread. It spreads locally through lymphatic, through transcelomic spread into the pleura, and through the hematogenous spread into the distant metastasis. How will you diagnose cancer? There are certain modalities through which we can diagnose the cancer. Which are those modalities through which we can do the laboratory diagnosis as early as possible and we give the proper therapy to the patient? One is biopsy of that particular tumor, that is histological examination by the paraffin embedded fixed section stained by H&E and other histochemical stains. Cytological smear, that means we take a FNA, fine needle aspiration from the particular organ and we get some tumor cells aspirated. We spread it on the slide and we see under the microscope. Another part is a exfoliative cytology, like we take a pap smear of the cervical smear. We take a buccal smear, the scrap cytology of the buccal smear. All these are the exfoliative. We see the urine examination. These are the exfoliative cytology. There the cancer cells shade into the body secretion and that we examine under the microscope. In this way, we see the cytological examination. The special examination which we can do is immunohistochemistry, detection of the surface marker or the self products by the monoclonal antibody. It can be used for the detection of cytokeratin, vimentin, desmin, calcitonin. These all are the tumor surface markers through which that is detected by immunohistochemistry or immunocytochemistry, through which we can make out that what is exact the origin of the cancer. See, like a gastric adenocarcinoma is positive for the cytokeratin. So if we see cytokeratin positivity, we can suspect gastric adenocarcinoma. There are specific tumor markers, the specific cell surface markers are there, which gives idea through the immunohistochemistry, and we can give the definitive diagnosis. Molecular diagnosis can be done by the DNA probe analysis and the flow cytometry. Certain tumor markers. These tumor markers we measure in the serum. So they are the value to support the diagnosis, to determine the response of the therapy, and through the level of which we can make out the patient is having relapse or not. Certain hormones like HCG, calcitonin, catecholamine, ectopic hormones. These are the different hormones which can be a tumor marker of the particular malignancy. Like if we do the serum calcitonin level, we can make out a patient is having medullary carcinoma of the thyroid. The level of catecholamine in the blood gives the idea about pheochromocytoma. So these are the tumor markers, serum tumor markers. Certain oncofetal antigens which is present in the blood, like alpha fetoprotein is commonly the level of alpha fetoprotein is commonly elevated in the liver cancer and non-semenomatous testicular tumors. Carcinoembryonic antigen is commonly elevated in the carcinoma colon, pancreas, lung, stomach, breast. Certain isoenzymes like PSA, prostate-specific antigen, which is specific for the prostate cancer. NSE, that is for the small cell carcinoma of lung or neuroblastoma. Certain specific proteins like M proteins or gamma globulins or immunoglobulins, they are commonly indicate the multiple myeloma or other gammopathies. CA125 for specific for the ovarian cancer, CA19.9 is specific for the pancreatic cancer. These are the mucins and glycoproteins. So clinical tumor markers is like this. If you can remember, it's well and good. If you cannot remember, it's fine for your level. But for the PG level, it is very important to remember the breast carcinoma has certain specific tumor markers. The stomach cancer has a specific tumor markers. Ovary has a specific tumor marker through which we can have an idea of, we give the support to our definitive diagnosis. We can see that a therapy is effective or not, and through the level of tumor marker, we can, if they are upregulated, we come to know that this is something which is related to the relapse. So it is important. The tumor marker is an important diagnostic aid for the cancer and for the therapeutic response. 4th February is a cancer day. You know red ribbon? It is for the AIDS, for the cancer, for the prevention of the cancer, for the preventive measure which is taken by the society for the cancer. They wear orange ribbon. We all are bound to wear orange ribbon because we all are doctors, and that's why we have our own responsibility to prevent the cancer. So 4th February is a World Cancer Day. Do something noble for the prevention of the cancer. Thank you very much.